Okay, hello everyone. Thank you for coming today. On our team, we have Sarah Brooks, Ginger Wilson, Mark Visconi, and myself, Dia Alcosairi. And we'll be addressing the challenge of maintaining the financial solvency of Boston Children's Hospitals while continuing to improve our quality as we enter into a bundled payment environment. We're here to recommend an RVU-based costing methodology across our hospital system. Just to give a little background, can someone help me with the presentation? So Boston Children's Hospital and other payers in Massachusetts, such as the Blue Cross Blue Shield, are already moving away from fee-for-service payment models. We have already been approached by some other private and public payers to negotiate bundled payment system. And the reality is that in 2014, bundled payment systems are coming. And we believe that global payment system will be the predominant method of payment moving forward. So our goal is really to enter into this bundled payment environment with the best understanding of our value and position in terms of cost, quality that we provide to our community. So to determine the cost of our services, we have implemented at BCH a pilot program to test the feasibility of a system-wide implementation of the time-driven activity-based costing methodology, TDABC. We learned from this pilot that TDABC has some advantages, but also many limitations. We found that TDABC does have the potential to capture cost in more details than other costing methodologies, and the process mapping that it requires allows us to identify areas for cost improvement, for cost containment, and for quality improvement that other costing methodologies may not offer. However, we found that TDABC requires a significant initial internal investment. It is a resource-intensive process, and it requires a lot of time and dedication from our providers, management, and support staff. The return on this large investment remains uncertain. There is also very limited evidence on the success of a system-wide implementation of TDABC in such a large and complex environment as we have here at BCH, with teaching, education, and research and community service missions. There is also lack of familiarity among other payers and stakeholders on TDABC. So we believe that there will be an additional investment in communication with external stakeholders about if you were going to use TDABC. We believe that our physician organizations are will be in particular challenged by the large investment that TDABC requires. The RVU system, on the other hand, is widely accepted by CMS and other payers. There's a lot of available data that we can use to benchmark our RVU calculations and our costs against other providers in similar markets. And RVU is already in place in our hospital system, which will make a system-wide implementation more feasible than having to introduce a totally new costing methodology like TDABC. We understand that that RVU does require routine update. There is some perception among some providers that it does not adequately capture the complexity of care they provide to their patients. And as some of our physician organizations are still using the ratio of cost to charges as their costing methodologies, and some other physician organizations are still exploring new ways to capture their cost, we believe that there will be some initial investment on their part, but we have identified strategies to address these limitations, and we're going to go over these strategies as we move forward today. And I will let my colleague Sarah introduce our team recommendation.
Okay, thank you so much, Dia.
Thank you.
Considering the limitations of TDABC, our institutional familiarity with RVUs, and the need to have a process in place in a relatively short time frame, we would like to make the following recommendations. The first is to expand utilization of our RVU costing methodology across our entire system over a 2-year period, and this would also include the physician organization. We'd also recommend implementing process improvement initiatives for high-cost and high-volume procedures. Our third recommendation would be to define, measure, and monitor patient-centric outcomes specifically by the organization. So while we are seeking to improve our processes, we are also wanting to ensure that we are engaged with our patients and that we continue to ensure that our care paradigm is one focused on creating value for our patients and their families. Our fourth recommendation is to establish a reward structure for our providers to incentivize them to adhere to our organizational goals, as well as to reward them for creating an enhanced value. Doing so will create a win-win-win scenario for our patients, our providers, and our system. So let's talk a little bit about expanding utilization of the RVUs. Expanding utilization of our RVU costing methodology across our system is an important step not only for determining costs, but also to determine an equitable means of allocating our costs as we move forward in a bundled payment environment. As it stands, the hospital and the physician organization both use different means of determining costs or use different costing methodologies that result in then different cost determinations. This practice will ultimately lead to a discordance as we divide payments for adequate reimbursement going forward. It is imperative that we take this time now, this short period that we have, to align ourselves together for cost determination and move forward as a united force in this changing environment. And we can do this quickly and efficiently by expanding our system utilization of RVUs. As part of this expansion project, we proposed the creation of a multidisciplinary RVU review committee. And this committee would be inclusive of select physicians, nursing management, and leadership. And they would be a resource to the physician organization as they transition to using RVUs. In the long term, this review committee would specifically be charged with reviewing our current utilization of RVUs, making revisions as warranted, and then updating our system on a regular basis. Because establishing and adhering to a review cycle is a necessary component to keeping our RVUs accurate, which also addresses two of the weaknesses that DIA identified for RVU utilization: the need for routine updates and striving to capture complexity of care. We plan to initially target our high cost and our high volume procedures in areas such as the emergency department and the surgical service lines. We're focusing on these specific procedures with the intent of seeing an immediate cost savings in our high cost and repetitive areas, and then also applying what we learn from these experiences across our other services in a tiered rollout. We understand that moving forward with an improved RVU practice involves a great deal of change, and that change can be difficult, it can be confusing, and it can be overwhelming. To address these strategies, we recommend developing an enterprise communication strategy that identifies key leaders in administration and the physician organization, and then also provides open communication without our system at large. Doing so will provide a uniform face to our physician partners and our employees and signal that the proposed changes are a cultural shift. This is not just another policy that we're enacting. Provider buy-in is essential to ensuring that our RVUs accurately reflect the costs associated with our procedures, and that consequently, our negotiated reimbursement structure covers our cost. I cannot stress this point enough. We need to align ourselves with our physicians and set ourselves up for success by accurately reflecting the costs associated with our procedures, and consequently, that our negotiated reimbursement structure will cover our costs going forward. Having physician champions within the rollouts of our departments is a key strategy to soliciting physician participation and commitment to this change. Drs. Waters and Shaw have already been approached and are interested in serving as initial physician champions. And their experience with and commitment to cost refinement and outcomes improvement is an invaluable asset, and we are so excited to work with them going forward. One other means of creating an enterprise communication strategy is also to have regularly scheduled town hall meetings to communicate not only our successes, but also our trials as we proceed with this rollout. These open forums are another avenue of communicating our commitment to excellence. And so with that, I'd like to turn the floor over to Ginger, who will talk about our recommendations 2 and 3. Ginger?
Thanks, Sarah. So I'm going to particularly focus on the second recommendation today, talking about process improvement strategies. As Dia alluded to earlier, one of the advantages of TDABC is that you're required to do a mandatory process map. And obviously, when you do that, you identify opportunities to improve your process. And so in conjunction with this RVU rollout, we want to implement process improvement strategies across our organization. The first thing that we want to do is identify these low-intensive procedures that can be shifted to less costly locations. We already have success here at BCH. We've already started to do that over the last 3 years, and we've captured more than $125 million in cost savings. So obviously, we feel like we can realize greater cost savings potential if we do this throughout our institution. The other thing that we also have experience with are these standardized clinical assessment and management plans, also known as SCAMPs. To date, we have 42 of those in place here at BCH, and we have identified ways to effectively reduce practice variation, again, realizing additional cost savings. So we feel like if we can employ this strategy across our institution, once again, we'll be moving in the right step. The other thing that we want to do is utilize Lean Six Sigma principles for those high volume and high complex procedures that Sarah identified, eliminating non-value added steps in the process, and also identifying ways to speed up cycle time and reduce wait time, recognizing that those are things that are going to improve patient satisfaction experience overall, and also open up access to care, because if it's providing, the same care at a lower time frame, we can get more people in and out of the system. And then redesigning services from the patient's perspective, implementing patient satisfaction surveys not only in our community physician organization environments with CAP surveys, but also within our institution, the HCAP survey. And then obviously recognizing that as we work towards these cost reduction strategies, that we cannot do that in the sake of compromising our patient outcomes. So those two have to be tied together. We have these 5 core outcomes here that we're going to standardize and implement throughout the institution, looking again at those patient satisfaction scores, cycle time reduction, avoidable complications, minimizing errors, and then also looking at appropriate lengths of stay. We're going to organize focus groups to define additional outcomes on those service lines that maybe we don't capture with our HCAPs and CAP surveys. And then lastly, we are going to have an internal dashboard to promote transparency and accountability of meeting these measures. I'm going to turn it over to Mark now.
Thank you, Ginger. So we realize that our patients come to our hospital for the care that's provided in part by our physicians and our nurses and our other providers, and that an enterprise shift to an enhanced RVU system may cause apprehension and uncertainty. To mitigate this, we would like to include our providers at each step of the process, from system design to benchmarking to annual review, and give them a chance to choose patient outcomes that are important in their own specific areas of practice. One of the criticisms of the current quality metric systems is the lack of relevance for some of the items employed. Unfortunately, this leads to little more than a box to check instead of meaningful tool to focus improvement efforts. While some of the current metrics will have to remain as a matter of regulation, we would like our providers to have maximum control over those that are added based on their expertise in patient outcomes. We would also like our providers to inform us as to what is important to them for rewards for meeting or exceeding these quality metrics. Bonuses, altered start times, flexibility in scheduling, etc. We will explore implementing these options through the hospital and the physician organizations. One of the reasons we are recommending the enhanced RVU methodology, it was out of concern for you, the providers. You are facing a number of complex changes, including electronic medical record implementation and a shift to the ICD-10 system. Had we pushed to the TDABC instead of RVUs, we believe there would have been even greater uncertainty and higher anxiety on our providers. We understand that our providers are the heart of our care and have other choices when it comes to admitting privileges and institutions for their careers. Our team has come up with a potential plan for the implementation of the enhanced RVU cost basis strategy. Phase 1 would encompass months 0 through 9 and consist of rolling out the infrastructure, communications, and executive provider champions, as well as forming the initial work groups to target high volume, high cost areas such as surgery and the emergency departments. Phase 1 would also roll out the physician incentivization program with rewards focusing on core values. Additional concurrent events will include Lean Six Sigma education, town halls, and area or team leads. Phase 2 would encompass months 6 through 18, allowing for some overlap to leverage the initial lessons gleaned from the optimization of the rollout in Phase 1. Phase 2 would focus on high volume, low cost areas and low volume, high cost areas, and also expand core values to areas or especially specific metrics. Phase 2 would also begin to lay the foundation to move to team rewards and ultimately towards organization-wide rewards for meeting core values. Finally, Phase 3 will serve to mature our educational program, roll out to low-volume, low-cost areas, and set up long-term sustainment and continuous pursuit of perfection activities. Thank you for your attention. We would now like to invite questions and discussion.
Good job, team. Well done. This question here is relevant to the fact that all healthcare providers experience frequent no-shows, scheduling and communication issues, particularly as it relates to incomplete information on a patient before the patient arrives. How would you measure the cost of those types of issues?
I can take this one. To measure costs, we would be looking at physician time lost as well as employee time lost, and then what it takes to reestablish this patient into our system and set them up with a new appointment or provide a new avenue of care. We could do this using the RVU system, especially looking at labor, so we can capture that cost that way. The other idea would be to capture ways to rectify this situation through our quality improvement process and by finding new ways to do things. It may be as simple as working with our electronic system to set up a stop, where if there needs to be certain information to get a patient set up or certain information to ensure that, yes, they were contacted, they were reminded about coming to their appointment, that they had all the information that they needed. And then if that information is not in the system, then they cannot move forward with that appointment and move it to the next level. So there are simple ways that we can rectify this using our quality improvement processes, and then capture those missed costs and rectify the situation using the RVUs.
Okay, thank you.
A good presentation, thank you. My sensitivity to the concern about the speed of change that you relate about what the physicians might be able to accommodate. We're not doing this in a vacuum at Boston Children's Hospital. And so my question is, will we be price competitive with the RVU implementation methodology as it relates to, for example, what Tufts is doing? They've already taken the advantage in many sectors with us.
I can answer that. We feel like the greatest opportunity here is really utilizing those regional care centers. You know, at BCH, obviously, we have 6 of those in place. And we feel like one of the opportunities there to be more competitive is to utilize those centers more effectively, identifying all those processes that are less complex that can be shifted out to the community. And we feel like Tufts has already done a really good job with that. And that's one of the things that we need to expand.
Great job. You know, I'm always so happy to see this because I know healthcare is in great hands for the future. It's interesting that you recommended the RVU over the TDABC. Answer me this. When I look at TDABC, I see a more meticulous costing method. And particularly when you're going into an era of decreased reimbursement, in my opinion, you'd have to really know what your costs are. So a little bit more I'd like to hear from you. Why the RVU versus the TDABC, particularly at this junction that we're in healthcare?
Okay, I can take that.
Because you're being innovators here.
Okay, so TDABC is a really great method to capture the accurate cost of a service, but it does not offer any options to reduce the cost. So to reduce the cost, we have introduced the process improvement process that we're going to implement, the 6 Sigma. I think the goal moving forward in healthcare is more to reduce the cost rather than spending a lot of resources capturing the actual cost of certain procedures or services. So we believe that within the 1 year that we have until the bundled payment system is rolled out in 2014, it's better for us to allocate our resources towards cost reduction and a good method that, like the RVU, to measure the cost versus investing all these resources into one method that will only capture the cost, but it's not going to allow us to improve the quality and reduce the cost. So we thought a better investment for us is to in the RVU system more than the TDABC system.
Now, the fact that TDABC also has a mapping process in there that would allow you to address that quality, you don't think that...
Yeah, we did consider that as a benefit to the system, you know, going in the Lean Six Sigma route, having a process map and looking at non-value added steps to cut out or waste and waiting. I think another area of concern for us with TDABC was the lack of implementation across the hospital healthcare system or across the world. We did a literature search and only came up with, I think, 3 institutions that were using it, and they were really on a pilot level, and including our organization. And additionally, we weren't quite sure how this is going to work out with the payers. since it's not a formally accepted system for cost analysis.
And just to add to that, I think our other concern was that we already had RVU implemented within the hospital system, and so we knew we were partially there. And even though TDABC, identifies things at a more granular level, we recognize that there were still so many opportunities within our system to reduce waste, that if we focused on those cost reduction strategies first, we actually could maybe within the time frame get there without implementing a full new TDABC system.